on the case as the medical expert pro bono. Every time that hospital sees Marty Makary on the case, they cancel the bill. Every bill is getting canceled. Why? Because I think they know it's egregious. These are egregious bills. They're not fair, and people are hungry for honesty in healthcare right now.
I would suspect that you're right, because if they felt that the only reason that they would cancel the bill is that they didn't want the public relations. And why wouldn't they want the public relations? It's because they didn't want the bill to be made public. Why wouldn't they want the bill to be made public? Because there's a problem with it. Do you like my deductive reasoning there?
Yeah, exactly. I mean, it's unfortunately many times they're forgiving these bills just out of a PR move, and they give us some corporate speak, statement. I've put these statements and their responses and my conversations with the hospital CEOs in the book, The Price We Pay. But what we're seeing right now is this sort of mass outrage that's going on in the general public. We've asked hospitals to take a code of ethics pledge, and we've got it on the website, restoringmedicine.org, asking them to agree to fair billing practices. There are certain things hospitals can do to be very fair. And look, hospitals will tell you they're on the brink of going out of business. That's true of some of the rural access hospitals, but Axios, the media firm, just completed a study showing, based on early 2019 data, large hospitals are on track for the largest profit margin in their history, 5.1%. So basically, the take-home message is large hospitals are crushing it financially, while small hospitals are closing. Rural hospitals are closing. They're not collecting billions of dollars from suing patients, garnishing their paychecks. Okay, these are hardworking Americans. Number one people getting sued in the state of Virginia, where we completed a large study that's come out in one of the medical journals, Walmart employees. They're the number one people that are sued by Virginia hospitals. Number two, food service workers. Number three, U.S. postal workers. Are these wealthy Americans? No, these are people who are working hard for their paycheck. Okay, they have health insurance. They've done nothing irresponsible by going without health insurance. Number four, hospital workers. Hospitals suing the very nurses and housekeepers and individuals who work at their hospital, have committed their lives to taking care of people. And
So
this
ironic.
is what they do with this care. I mean, it's a disgrace.
That being said, let's talk about employers for a sec, because obviously if your workers' wages are getting garnished by the local hospital at scale, that is knowable. You can see the wages getting garnished. Obviously, employers do have a stake in this. Is there any advice that you would have for employers, many of whom listen here? Should they be teaming up with any of your advocacy groups, or what's your advice to them?
First of all, I love employers. Right now in healthcare, they are the bright spot. And overall, I'm very optimistic about the future of healthcare because we're seeing a redesign of care, a return to honesty by people like Keith Smith in Oklahoma and Columbus Community Hospital in Nebraska, and many of these great players. And employers are smart enough to say, hey, we want to work with the honest hospitals, not just the ones that advertise at the NFL games. Like, we can see through this stuff and we see the egregious pricing that's going on. And we want people that we're willing to pay for quality, but we want honest and fair pricing. And we want to be able to see how you're doing in terms of quality. And billing quality is medical quality, and employers are seeing that. So we've talked to Walmart. We've told them, hey, your employees are getting sued like crazy in the state of Virginia. Here's the data. My research team from Johns Hopkins has done the research on this. We've got the studies. Here's the data from the state of Virginia. Walmart employees are the number one employees that get sued and have their wages garnished. Will you help us? Right? Employers have tremendous clout in healthcare, tremendous. Not only do they serve on a lot of the boards of hospitals, but once they find out about things, when they learn about things, they get involved. And so we're seeing that now with employers. So all those employers out there, gosh, you guys are the future. You guys are driving competition in local marketplaces, and we just need good metrics, just like the food industry developed food labels. The industry initially fought food labels, the food industry, saying that, this companies are going to close. We're going to have food shortages. People are going to be laid off. All of this gloom and doom when food labels were introduced as a national transparency policy. None of it happened. It didn't happen. What we got was an incredibly informed consumer. And that's what we see in healthcare with employers.
Moving on to the second kind of category of overpricing, if you will, and that is overtreatment or wasteful treatment that might be charged for at a very high price. As you said in the book, 21% of care might be considered unnecessary. And then we have the whole, as you termed it, which I loved, screening industrial complex, which kind of furthers that end. Do you want to talk about the situation there and how this compounds the earlier part of our conversation?
Yeah, there's two problems in the issue of the appropriateness of medical care. One is undertreatment, and the other is overtreatment. But right now in America today, by far, the number one problem we face at epidemic proportion is overtreatment. Both are problems. Let me give you a statistic, Stacey. 10 years ago, we physicians in the United States prescribed 2.4 billion prescriptions. Last year, it hit 5 billion. Did disease double in the last 10 years? No, we have a crisis of appropriateness. Isn't the opioid crisis one manifestation of the crisis of appropriateness? We have patients getting overpriced bills for services they didn't even need. 21% of all medical care is unnecessary in that statistic you quoted. And that was from a survey of U.S. physicians that we published in a Johns Hopkins study surveying 2,100 physicians across the United States in all specialties, a random sampling, simply asking them, what percent of medical care, in your opinion, is unnecessary? When you have people in the industry telling you that 21% of the stuff going on is unnecessary, that's a wake-up call. That's a signal. That's a red flag that the number one way to reduce the drug pricing problem in the United States is to stop taking drugs you shouldn't be on. The number one way to reduce healthcare costs in the United States is to reduce unnecessary healthcare. The number one way to reduce the cost of back surgery is to reduce unnecessary back surgery. And what I'm so excited about, one of the reasons I'm so optimistic about the future of healthcare in doing the research for the book, The Price We Pay, is that a whole generation of doctors are saying, hey, wait a minute, this system is broken. Burnout rates are at an all-time high, not because we're busy. We doctors like to be busy. It's because of this treadmill that we're on where we're forced to see patients in 10 minutes and people come in demanding a prescription they don't need or a test they don't need. And we're seeing a generation of doctors, mostly led by these millennial doctors and the new generation, that are saying, can we talk about the crisis of appropriateness in medicine? Can we look at how the perverse incentives have created this monster complex? Can we talk about how to treat gut problems with healthy foods? Can we treat back pain with yoga? Can we treat loneliness with community? We're seeing this incredible movement to ask, how can we talk about the root drivers of poor health instead of just this reactionary treatment complex that we've been conditioned to recognize from our medical education?
Is a way to accelerate that. So if I am a lone doctor who's listening to this podcast and I have embraced the mission and I see that my organization is not aligned with my mission is to improve patient outcomes and to reduce the harm that is caused by taking unnecessary medications or getting tests or treatments. There's always a risk of everything. So the more unnecessary treatments that get piled on, the more risk that you're actually going to have an adverse reaction. It's the medicine that'll kill you, right? Is there a way for me to accelerate this other than talking to my leadership? Or does it all boil down to get involved at the higher levels of any of the organization and try to fix this from the inside?
Well, there's an incredible groundswell of physicians and nurses who are saying, let's be a part of a grassroots movement to just scrap the current healthcare system and start from scratch. Now, these are largely driven by primary care physicians. And they're basically saying, look, this model of 10, 15-minute visits and cramming all these patients in, this is for the birds. We don't like it. Doesn't make sense. It's not good for patients. This is not how we ever, intended to practice medicine. So they're educating themselves now on food as medicine and what we call the holistic treatment of lifestyle diseases. I'm not talking about all the quack therapy. I'm talking about stuff that works. We're talking about, addressing what are real problems. And one of the most exciting innovators I came across in doing the research for the book, The Price We Pay, was the so-called, what I call relationship-based clinics. It got that name early when they started. There are a couple of these big relationship-based clinics out there. They go by the names ChenMed, Iora Health, Oak Street. There's others as well. But these groups have said, look, we're not going to bill you for everything. We don't believe in that model. It's not good for doctoring. We'll take a global lump sum payment from the Medicare Advantage plan or from an employer, and we're going to do direct primary care. We're going to be there for patients, and we're going to prevent disease. We're going to look at their posture and sitting in the workplace and prevent carpal tunnel syndrome. We're going to be available for them to call us in the middle of the night when they think about going to the emergency room for something that can be treated at home, or they can treat it through telemedicine. So we're seeing these relationship-based medicine clinics thrive at a time when traditional primary care medicine is getting hammered and is having trouble recruiting people. People love it. These doctors and nurse practitioners and you name it. There's kinesiology majors from college who come right out of college and work as a care navigator at Iora Clinic, because Iora hires based on empathy, compassion, and work ethic, not on your degrees in formal training and experience. And so they attract incredible talent, and they sit around a conference table in the morning before the patients come in, and for an hour, they talk about who's coming in, what are their social determinants of health, what are their unique circumstances. The front desk staff comment on what the patient said when they called the patient to remind them of their appointment. The navigator, and every patient's assigned a navigator, could be somebody, out of college who was hired on compassion and empathy and work ethic. And the doctors and nurses train that navigator as to what's important in the patient. And guess what? These bright, smart, creative people, they learn and they do a great job. And by the way, they're hired at a lower price point than an MD or a nurse practitioner. And it's okay. I can teach a high school student how to do wound care in my surgical clinic. So Iora has basically said, let's let doctors come up with this sort of vision for care, and let's allow an entire team to coordinate it and administer that care. And so Iora Health Clinic was very exciting. ChenMed, Oak Street, all the same. Just incredible stories I got a chance to describe in the book, The Price We Pay.
In a way, this is very practical common sense. And I know common sense doesn't grow in everyone's garden, but what you're saying, everybody had a grandma who had a social calendar that included visits to the cardiologist. And it's, so a cardiologist is basically her answer to loneliness. Exactly like you said. And I don't think it necessarily takes a rocket science to realize that she didn't really need to go to the cardiologist. She wanted something to do on Tuesday afternoon. Oh, there's that. Do you want to talk about practicing wisely, which I was fascinated by?
Yeah, sure. By the way, another great thing about these relationship-based clinics is some of them take on the downstream financial cost of the patients. They assume that downstream financial risk. So guess which cardiologist you think these relationship-based clinics are sending their patients to? The one that does a stress test and a nuclear sestamibi on every single patient? Or the ones that have sound judgment and are judicious with the practice of medicine? Are they sending their patients to gastroenterologists that tell every patient you need to have an annual colonoscopy, despite the guidelines suggesting it should be done every 10 years in healthy people? No, they're sending their patients to doctors that deliver good, appropriate, sound medical care. And what you're seeing is that when you let doctors manage patients and do it with the right alignment, both of the ethics and with the moral backing of an organization with a great organizational culture, and you align the financial incentives, you see doctors doing the right thing, and it's beautiful. And it turns out that these clinics lower the overall healthcare spend for a population by at least 15%. So a real bright spot.
Yeah, and I can really see that. And I know this is just one anecdote, but every anecdote is a data point, right? You had my grandmother who's 93-year-old diabetic with an artificial heart valve, and she's going to her cardiologist for a stress test to see if her heart valve is still functioning. In which case he always would say, well, it might have some problems, in which case she'd be at the emergency room 8 times after that because she was thinking she was having a heart attack and was going to die. Cases like that are appalling if you know anything about anything pretty much, and really costly. So practicing wisely, which is an initiative, maybe is the best way to call it, that you have founded.
Yeah, so the Robert Wood Johnson Foundation funded Choosing Wisely several years ago, which I think is just a wonderful project with this incredible leadership from ABIM Foundation and Dan Wolfson. And they've really done a tremendous job creating awareness around the issues of overtreatment. Well, our thought was, can we take things a step further by providing actionable data to individual physicians beyond the sort of public awareness campaign within the medical community and for the public? Can we go a step further? And that's really the genesis of Improving Wisely, which was another grant from the same Robert Wood Johnson Foundation to say, let's share individual data with physicians on how they perform. Let's do it in a confidential way, and let's let doctors define what the quality metric is. Let's let doctors create, develop, and endorse how they should be measured on appropriateness. And let's not just look at complication rates, which is what the entire quality industrial complex has been measuring. Let's look at the appropriateness of care. Did that patient need a knee surgery? Should your senior patients in your practice be on 15 medications when the national average is less than 8? So what we did is a benchmarking program, sending physicians reports on how they perform around an appropriateness measure that was defined by the experts in the specialty. And what we found in some of these projects is that it had a tremendous impact. Take skin cancer surgery, for example. We just published in one of the JAMA journals that when you send doctors who do Mohs surgery, their average number of blocks per case or stages per case, those on the extreme, those who are practicing outside of a boundary of what the peers consider to be reasonable variation, they autocorrect. When they're sent that letter, they autocorrect. It's kind of like when I discovered in the research for the book, The Price We Pay, the San Diego coroner, when he found a patient who died of an opioid overdose, he sent a letter to the doctor, the prescribing doctor who was prescribing opioids. And guess what happened to that doctor's prescribing patterns? They plummeted. And it's the simple courtesy of civility and closing the loop that had this powerful auto-correction impact on physician behavior. Nobody got in trouble. No one got penalized. No one went to jail. There was no expensive consultant. This was simple peer-to-peer benchmarking using sound data that was developed by physicians. The Mohs surgery project we published in JAMA cost $150,000 to run that project nationally. That project has resulted in an $18 million savings to CMS in payouts in the first 1.5 years. So it's had a tremendous impact. People are recognizing that, number one, we need to measure appropriateness of care, not just complication rates. And we can do it by engaging doctors, and they will police their own house and encourage their outliers to autocorrect. I call the outliers those who need help rather than those who are, bad doctors. This has tremendous implications for healthcare. So that's part of this Improving Wisely, Practicing Wisely effort.
And I can see that as a really sensible alternative to heavy-handed prior auth requirements, because just given that Mohs surgery example, another way to handle that would have been if you're going to do more than 2 sections, you have to call for prior authorization. That's another way to handle that. What this is effectively doing, every patient is unique and every patient has individual needs. So instead of micromanaging, let's just look at the practice pattern as a whole. As you said, it enables each individual provider to police themselves or to know what good looks like relative to appropriate care, which, is not necessarily something that in the absence of seeing other doctors and how they practice.
Yeah, what if we could gold card physicians? Your practice patterns represent a pattern that's appropriate. You do well on the appropriateness measures. And because of that, you're not going to have to get pre authorization for your patients. You're not going to have to do a peer to peer or have an insurance company tell you what you can or can't do. And that means you have liberty to practice the art of medicine. What if we start gold carding physicians to give them the freedom to practice medicine as they see fit? I mean, after all, isn't medicine a science of tailoring treatment to an individual's goals and needs? Isn't it an art form? In many areas of medicine, it is. So that's the exciting thing going on right now in healthcare, the talk about appropriateness, the ability of physicians to come up with new measures of appropriateness, and sort of the mass effort to create true competition in healthcare by creating transparency, not just around price, but also around quality. And I believe once we have price transparency, it will usher in quality transparency with much more speed and rigor than we've ever seen.
Marty, is there anything that I have neglected to ask you that you feel would be important to mention?
I mean, I can tell you a little anecdote here that I love being a surgeon. And being a doctor, I think, is the greatest profession in the world. To have a patient tell you things they wouldn't tell their own spouse within seconds of meeting you just because you're the doctor, it's an incredible public trust. Or they'll trust you to put a knife to their skin within a minute of meeting you because of the heritage of medicine and the public trust. It's an incredible profession. Doctoring, being a nurse, respiratory therapy, you name it. It's an incredible profession. And the patients sometimes don't know how to navigate the system. I've got patients who show up in my office and I'll ask them, how did you decide to come to Johns Hopkins? And I'm thinking they must know that we do more pancreas surgery than any hospital in the world. And they'll say something like, well, the parking here was really good, so that's why I decided to come here. And you realize people are not shopping on value. Employers are not shopping on value. Instead, healthcare has competition now, but it's competing at the level of parking and billboards and NFL ads. We should be competing based on price and quality. People are willing to pay for quality, but they just want honesty with quality metrics and with pricing information. So I think we're about to see an unleashing of more competition in healthcare that's for the good. It's badly needed.
Dr. Marty Makary, thank you so much for being on the Relentless Health Value podcast today.
Great to be with you, Stacey.
Links to everything discussed on the program today can be found at relentlesshealthvalue.com. If you visit the website, relentlesshealthvalue.com, you will also find a complete listing of all of the shows that we have published thus far with leading entrepreneurs and executives in the healthcare space today. Another cool feature is, you can subscribe to the show so that every week the episode is automatically sent to you, so you don't have to remember to go to the website to download it. Thanks so much for listening.